What happened, madam?
Very good evening, sir.
Good evening, all. This is Chandra Mohan, physiotherapist from Exercise Testing and Prescription, shortly known as ExRxIndia. And today we are having a postgraduate entrance test online coaching, which is available on our YouTube channel, Fitness and Rehab India. So today we are having resource person, Dr. Arun Balasubramaniam, former principal, PG College of Physiotherapy, Coimbatore. I welcome you, sir. And I welcome all the participants, and I welcome Professor Duna to help the session running smoothly. Please, sir, please start. You can share the screen, sir.
Is it visible to all?
Sir, go for yes, sir.
Right. So, happy evening, friends. As we discussed in the last class, and here we are for the today's session about multiple choice questions on manual therapy. Although I was not able to identify much questions in the manual therapy, but still I was able to clear because manual therapy is a part and art of treating the patients. It's like a hands-on technique. Although you don't find much of theoretical part, the manual therapy is of lot of hands-on technique. But still, as a part of studies, you are supposed to understand the theories, right? So we are moving same as last time as you are attending the 3-4 sessions. Please type answers on your chat box. I will go and check it and I will discuss the correct answers. Before going well into the class, first I will discuss very brief about manual therapy. Manual therapy is not able to take it in 1 hour. Manual therapy was lastly divided into 2 types. One is called the joint mobilization, other one is the soft tissue mobilizations. Joint mobilizations are the mobilizations where you are going to mobilize the joint, like the Mulligan's manual therapy or Maitland manual therapy or McKenzie manual therapy. So where you are going to mobilize the joints. Or the soft tissue mobilization or focusing on the soft tissues, fascias like myofascial release, muscle energy techniques, or Cyriax mobilization, which are going to focus on the fascias, right? So these are 2 different extents. Whereas the McKenzie manual therapy or McKenzie technique, which focuses only on the spinal joints, cervical spine and lumbar spine. Now they start devising it in the limbs also, but now they are focusing on the cervical and lumbar spine, right? So this is about a brief introduction about manual therapy. We'll go on, we'll see a lot of things here. Before we go well into that, I have some photographs and you are supposed to say what is the technique or what the photograph implies, and same as the question answers. Right? We'll start from basic till the higher end also. The first question for you is, all the statements are true about osteokinematics, right? So except which is not the osteokinematic here, or which is not the statement about osteokinematic here. First is movement can be visualized, movement can be measured, all also called as physiological movements or movement occur inside the joint, which is not the statement about the osteokinematics. Movement can be visualized, movement can be measured, or also called as physiological movements, right? So it is the answer B. It is the physiological movements. Right. So it movements occurs inside the joint because osteokinematics are also called as physiological joints, where you are not able to find out what happens inside the joint, but when the joint happens inside only, you are able to have a physiological movement, right? So this is D is the correct answer. We have 2 types of kinematics. One is called as osteokinematics, and another one is called as arthrokinematics. Arthrokinematics are the or happens inside the joint, like rolling, sliding, gliding, and all. This is very important to get a full range of motion. When you put your shoulder to flexion, there is some movement happens inside the joint, which we are not able to visualize. Whereas in osteokinematics, we are able to visualize. We find that there is a movement is there, but we are not going to assess it, right? So that is the first question. Right. Second question is a picture. What this picture says? What this picture says? What is the technique? So I'll give a clue. It is a McKenzie manual therapy. Any guess? McKenzie extension, right? Okay. And some mechanic, it's McKenzie. Right. So the right answer is lying prone in extension. McKenzie manual therapy has got various lumbar techniques. Like there are about 17 techniques in the McKenzie manual therapy. And the first technique is lying prone, and the second technique is prone with the hand. Right. So you are going to extend the lumbar spine and producing a movement. So McKenzie is very, very important for the lumbar spine. Right, question number 2, in Freud's law. That Freud's law is the common law which we are going to use it in the spinal manual therapy. Without knowing this law, you are not able to go and do the spinal manual therapy, right? You have to understand what is the mechanics behind it when you go for a spinal manual therapy. In Freud's law, when the rotation and side bending occurs in the same side, they are called as, is it law 1, law 2, law 3, or law 4? Freud's law, when the rotation and side bending occurs in the same direction. What is it? So when you ask the patient to do side bending and rotation, the facet joints will produce rotation and side bending on the same side. What is it called? Law 1, law 2, law 3. It is law 2, right? So I will explain it. Freud's law. What is Freud's law? Freud's law is law 1 is side bending of the spine in one direction, which results in rotation of the opposite side. This is, we call it as a neutral mechanics. When you do side bending, it occurs rotation on the opposite side. It's a neutral mechanics. The law 2 is side bending of in one direction, results of the rotation also in the same direction is law 2. And law 3 is increased range of motion in one plane, which causes decreased range of motion in other plane. So law 1 is called as neutral mechanics, which you can find out in the subcranial spine, in the lower thoracic spine, lumbar spine, and the sacrum. This is neutral mechanics, which you are able to find out. If you are not able to find out this, it is non-neutral, then you say it is a pathology there. And law 2 is the non-neutral mechanics, where you can find out in the mid-cervical and in the thoracic spine. That is side bending in one direction, rotation in the same direction. That is seen in the mid-thoracic cervical spine and the upper thoracic spine. So when you see that is in differs, right? So in mid cervical spine or lower cervical spine, the side bending in one direction and rotation opposite direction, then there's a pathology there. The law 3 is very simple. When you ask the patient to bend and do rotation, the patient was not able to do rotation. Whereas when the patient asked the patient to sit erect and do rotation, the patient was able to do rotation. Whereas when he bent to one plane, the movement was totally restricted. That is the law 3. Right? It's very, very simple. You can find a lot of YouTube videos related to the Freud's law. Right? That's very important to do, especially the spinal mechanics. Right. Today, question number 3 is traffic lights. Right. Usually, the McKenzie tells you you should stop the treatment. What light you have to tell that you have to stop the treatment? Is it green light, red light, amber light, or yellow light? McKenzie manual therapy has some lights which helps to identify each and every component. Very, very easy question, right? Red is for stop. Anything when you're driving, it says red is stop. So same as here, red light says that the thing is worsening. You are doing a McKenzie manual therapy, asking the patient to lie on a prone lying with elbow flexion or prone lying in the Sphinx position, and the patient says the pain is increasing or symptoms increasing. The patient has a radiating pain. Immediately stop the treatment, right? So do not continue the treatment. Whereas green light says the patient is getting better. Sir, when I do a Sphinx position or when I lie prone, my pain is reducing. Okay, encourage the patient to do that position. Whereas amber light indicates that when the patient lies on prone, sometimes pain was increasing, sometimes pain was decreasing. When the pain is decreasing, you can encourage the patient to continue it. The pain is increasing, you ask the patient to stop it, right? Amber yellow light is you have to ready for that. Either it is bad or good, you have to ready for that. So red light means stop, green light means continue, amber light means wait for it. That's based on McKenzie technique, right? What is this light? Very, very easy question, but still I have a catch here. Which movement is improved in this light? This light, you know everyone, but what movement is improving in this light? Abduction, Adduction improved by infinite length. Internal rotation and external rotation. Either one rotation only will improve, not two rotations will improve. Adduction is the right answer, right? So this, what is this glide? Name the glide. Tell me the glide. Sphenohumeral, posterior glide. With deflection 90 degrees. It improves adduction. Usually posterior glide improves what movement? Posterior glide improves flexion. When you do posterior glide, the flexion movement will increases. Right? With horizontal 90 degrees of flexion increases horizontal adduction. So next question is, when the patient complains neck pain, so I have neck pain soon after he gets a what it indicates? It's excessive use of computers, stress, poor pillow positioning, or posterior neck muscles. What is the common condition where the patient complains pain soon after he wakes up from the early morning, he feels pain? You have the correct answer. Poor pillow position, right? So very simple thing, right? As I think last class you have studied the assessment of musculoskeletal in the Maggie. It says clearly, if a patient complains of pain in the neck in the end of the day, that is in the morning till the evening, he does work, and the evening he has got neck pain, it is because of posterior neck muscle weakness. You have to strengthen the muscles. Whereas when the patient sleeps and wakes up in the morning and complains of pain in the neck, it is because of two reasons. One is pillow positioning, other one is because of poor mattress. So that has to be taken into consideration than going for the muscle weakness. If it's a too high pillow also causes saltation in the spine, too low pillow also causes saltation in the spine. Neutral pillow, like a soft pillow which is neutral, only helps the spine in the neutral position, which prevents the pain. So very simple reason, you ask the patient when your pain is increased. Patient says that in the early morning I have severe pain. That is maybe because of the poor position. Most of you has put the correct answer. Very good. Right. So non-thrust oscillatory technique, that is Maitland technique, is applied with a large amplitude rhythmic oscillation, which are performed up to limit of the available movement. That is the Maitland grading I'm asking. It's a different form I just put it. Non-thrust oscillator technique is applied with a large amplitude rhythmic oscillation which are performed up to a limit of available movement is grade 1, grade 2, grade 3 or grade 4. Grade 1, grade 2, grade 3 or grade 4. See, it is grade 3. Answer is grade 3. How it is grade 3? Because grade 1 is small amplitude movement out of resistance. I will show the picture in the other questions. I have another question related to that. Let me show the pictures. Grade 1 is small amplitude till the resistance. That is the beginning range we are doing it. Grade 2 is large amplitude out of resistance. But still we are not touching resistance. You are going to move a joint in a large amplitude but still into the resistance free area. Grade 3 is large amplitude into the resistance. You are just touching resistance. That is the question here. Right, so which are performed up to the limit of available movement. So that is grade 3. And grade 4 is small amplitude to resistance. You are just going well into resistance is grade 4. And grade 5 is high velocity thrust. That is also called as, some textbooks says as a manipulations. That is, patient renders powerless to prevent it. Patient was not able to prevent it. Sudden movement, what you are going to do, patient is not having a power to prevent that movement. Whereas mobilization, patient is always controlled movement. As manipulations, patient was not able to control it. Right. So pain management through non-thrust intermittent distraction applied for how many seconds? How many seconds? When you apply a non-thrust intermittent distractions, release pain. That is as simple as a Calton-Bonds technique. Calton-Bonds technique is a distraction technique, whereas Maitland technique is an oscillatory technique. Right. So that's the main difference between Calton-Bond and the Maitland. So it is 5 to 7 seconds. 7 to 10 seconds, 10 to 15 seconds, or 15 to 30 seconds. Like most of you given wrong answer. You're passing right, you are right. You are the only person right. 7 to 10 seconds. When you apply the non-thrust intermittent distraction for 7 to 10 seconds, the pain will relieve. Okay, this was told by the Calton bonds concept. Calton bonds concept is a distracting techniques, whereas the Calton bond has also got a gradings, right? Same as Maitland, and Maitland techniques are oscillating techniques. Okay, what is this technique? Okay, what is the name of the technique? Just tell the name of the technique. I do not want to explain. Great explanation. Some like technique they are doing. What is the name of the technique? Very simple. Please tell me simple form. Cervical mobilization, right? What is the other? So which we are not able to use it regularly. You have a lot of practice when you apply this technique. Cervical thrust technique. This high velocity thrust technique for the cervical spine, right? So when the patient does, or when the therapist does this high velocity thrust, you find an audible click in your ears, especially in the cervical spine, lumbar spine. Some expert was able to do click sound in the shoulders also, right? Shoulders are very important. Especially you are, but very easily everyone can do. When you practice it, you are able to do this click technique in here. But high velocity thrust mobilization are to be done very carefully, because when you do this technique, you have to be very careful about the cervical structures. There are nerves, there are muscles, there are ligaments, and the bones are very tiny. So you have to be very careful on doing this. You need a lot of practice on doing this. So do not attempt it for all the patients. Select the patients before you start doing this high velocity thrust technique. Or the dangerous technique in physiotherapy, actually, you can say. Right, question number 7. Which one of the following is not mechanical pure interface of the nerves? Is it fascia, blood vessels, edema, or the muscles? Which is not the pure mechanical interface? Here I am dealing with the Butler's manipulations. Right, Butler's means everyone knows about the upper limb tension test and the lower limb tension test. These techniques are described by the nerve tissue mobilization techniques. And very good. Everyone has put the correct answer. It is edema, right? So edema is the right answer. So edema is the right answer because the mechanical interface, and then the nerves from the cervical side, it reaches to the fingers. It has to pass through the fascia, blood vessels, and the muscles. Any entrapment in the fascia, any entrapment in the muscles, which may also got pain, like entrapment in the bones, right? Like thoracic outlet syndrome. Entrapment in the muscle, which causes the radial tunnel syndrome. Here in the facial results in the carpal tunnel syndrome. Everyone is different. This is a pure mechanical. So edema is a not pure mechanical, right? So when you do glidings, when you do upper limb tension test or lower limb tension test, SLR, slump test, brownie bending. When you do that, you are able to relieve the nervous tissue tension and get the normal range of motion of the nerves. Right, the same Butler's mobilization. So any Butler technique, when you read it for your theory, the first thing you have to understand the Butler's is the tension points. Tension points of the spine are those where no movements of the nervous system takes place in relation to the interface. Here there is no movement takes place. Which is the place where no movement takes place in the nervous system? That is what is tension point. Which is the place? Is it C5, T6, L2 or C6, T6, L4? C1, C2, T12, L5 or C7, T1, T12, L1. So which is the place? C is the wrong answer. B is the right answer, right? So it is C6, T6, L4 where the nerve doesn't produces much movement. Where it produces very mild, a tiny movement. C6, T6, L4 are the tension points where the nerve doesn't produce any movement. It's very important if you are dealing with the Butler's manual therapy or the nervous tissue mobilizations. Right, one of the general questions I just put as mechanoreceptors which are stimulated by application of manipulations or mobilization techniques. These mechanoreceptors are thickly encapsulated in conical corpuscles resembling fascial corpuscles. Right, so what is the type? Is it type 1, type 2, type 3, type 4? Actually, we have Golgi tendon organ, which says it is look like a type 1, type 2, type 3. Expansive corpuscles are like a type 2 fibers, right? So these fibers are stimulated when you apply manual therapy techniques or when there's a pain. These fibers are stimulated and carry the impulses from the brain to the spinal cord. Like what is the guide? Very, very simple question. What is this guide? So come guide for the lumbar spine. What is it? What is this guide? Very simple. Maitland's manual therapy for lumbar spine. So what technique we apply? We always used to apply posterior anterior blade. Right? So this is helps to reduce the pain as well as improve range of motion. So make the patient in a prone lying, palpate the spinous process, apply the posterior anterior blade. So from the posterior, you are going to mobilize the spine, which helps for relief pain. You have to have a good idea before application of this. Right, so another question in the soft tissue mobilization. Cyriax massage are applied deep and dash to specific tissues. Is it transverse, is it longitudinal, horizontal, or parallel? Cyriax massage. So how the Cyriax massage are applied? Right, it's a transverse, very easy question. Everyone has a correct answer. Transverse technique only, it is a Cyriax technique, right? So when you apply Cyriax techniques are deep friction massage, which is applied transversely to the tissues. And Cyriax says that you have to treat the cause. So when there's a pain there in the elbow, you have to apply a deep friction massage to the elbow, which helps to reduce the pain. So pain was relieved by application of deep tissue massage. Right? Cyriax basic concept is a deep tissue massage. Okay, so now we are moving on to the fascia. All the statements regarding superficial fascia are true, except so all these statements are true for the superficial fascia, except it is tough, tight, and compact, loosely knit, stores fat, provides shock absorption. It is tough, tight, and compact, loosely knit. Wonderful, excellent. Everyone has put a right answer. This first one is the right answer, wrong answer. It is loosely knit. It is not tough, or it's not tight, or not compact. Superficial fascia are loosely knit so that when you apply a myofascial release, you are able to go penetrate into the fascias, right? Superficial fascia is loosely knit, it stores fat, encapsulated with the fat, and provides shock absorption. So when you look at the fascia, we have superficial fascia, deep fascia, and visceral fascia. Right? Superficial fascia is just beneath the skin, deep fascia is still behind the superficial fascia, and the visceral fascia covers the organs, internal organs, so visceral fascia. Fascia is a whole body network, right? When you read the facial anatomy, fascia is totally different from the normal anatomy. Although we are not having a strong studies on the fascia, but facial therapy also produces a lot of wonder in musculoskeletal rehabilitation. Right? That question number 2: myofascial release therapy are performed with oil, powder, gel, or no? Nothing else. What we have to use when you apply a myofascial release therapy? So powder, oil, or gel, or nothing. Usually for general massage, we use oil or powder because here we are focusing on general massage focus on relieving the superficial structures, whereas myofascial release focused on the deeper tissues. We should not use any of the substances like oil, powder, maida, gel. Nothing should be used because it prevents the friction between the fingers and the skin. So it produces sliding over there. When you use some powders, the grip will not be there. The friction was reduced, so you are not going to do a appropriate technique, or the technique will not reach the fascia. So nothing should be used when you apply a myofascial release therapy. The patient should be cleaned well, and your hands also should be cleaned well. No nails should be there, and you have to apply a good myofascial release to the patient. Right? There are a variety of techniques of myofascial release therapy. Right. So what is this mobilization? What's the name of the mobilization? It's a Mulligan's technique. So it's a Mulligan's. Name of the technique. Any guess? Just write that one. Just write. There's some technique the therapists are doing in the neck and ask the patient to do a shoulder movement. It is called as
Someone from YouTube.
Yes, sir.
Someone from YouTube responded, sir. Scapular mobilization.
No, sir, it is spinal. Scapula, no way is touching it. He is touching the spinal. Right, it is a spinal mobilization with the arm movement, right? So as per the Mulligan's technique, when you do a mobilization of the cervical spine and the patient have a radiating pain in the shoulder, he started doing the mobilization and asked the patient to produce the arm movement. Thereby, he was able to reduce the pain. Right? So Mulligan's mobilization are always focused on weight bearing position as well as with the movement of the limbs, upper limb as well as the lower limb, so that the movement, the limb movement also encouraged as well as when he does the movement in the spine. Right, question number 13. Myofascial release, the collagen began to change only after passage. How many seconds needed for the fascia or the collagens to break down when you apply myofascial release? It is 10 to 30 seconds, 50 to 90 seconds, 90 to 120 seconds, 100 to 180 seconds. How many seconds? D is wrong answer. Those are minus. Right here. The correct answer is 90 to 120 seconds. When you apply a facial release therapy for 90 to 120 seconds, that is for like 1.5 minutes to 2 minutes only, it started doing a collagen breakdown. Just applying for 1 minute doesn't help, right? You have to apply at least for 3-4 minutes so that the collagen starts breakdown and you are going to reach the appropriate technique. Although these are very, very minute questions I am asking, still it just okay. Next question: movement of the radial head at the humeroradial joint in the forearm. Supination position is example for gliding technique, spinning technique, rolling technique, or distractions. Right. So what is this? Movement of radial ulnar head. So supination positions. So the radial head. What is this technique? Very easy. Spinning. Spinning not only produced in the here but also happens in the shoulder. When you do internal rotation, external rotation, the spinning occurs. Hip joint, when you do rotations, the spinning occurs. Spinning happens when the joint produces lot of movements. Right? So rolling and gliding occurs same as these are arthrokinematic movements. Right? Happens inside the joint, which cannot be quantified. But when this movement are not producing, the osteokinematics, physiological movements are not possible. There's a restriction in the physiological movement. Patient comes to the PA shoulder and the patient says, I was not able to lift 90 degrees above. But the problem is happens inside the joint, right? So when the gliding, sliding doesn't happen, then we are giving a joint mobilization to improve the gliding and sliding so that we are going to improve the physiological movements. Right? So these are the basic concepts of the arthrokinematics. Very easy to see. In PNF training, D, what is stands for? D1 flexion, D2 extension. People say D1. What is the D stands for? Digits, directional, development, or diagonal? What is the D stands for? The answer is D. Very good. So because the one time this was asked by examiner in exams, and most of the students has told wrong. They forgot it's a diagonal movement. They say direction, they say digits. Because of tension, they are not able to come up with the right answers. Right? So I have two questions in the PNF. Okay, I'll just go through it now itself. I'm opening the sequence. I have two questions in the PNF. We're supposed to identify what is the thing. Right, so everyone has correct answer here. Okay, this is one of the McKenzie manual therapy. What is the name of the technique? And how many thoracic vertebrae the patient has to come outside? Two questions. What is the name of the technique? And how many thoracic vertebrae, how many thoracic vertebrae does the patient has to come outside? Very good. Okay, we'll say in a little medical terminology, chin tuck is okay. Little medical terminology. This is called a supine retraction. So neck retraction with the head out of the bed and the head has to out for third and fourth thoracic spine, right? So it is supine retraction technique where the patient has to support the head, come outside of the head for 3 to 4 thoracic vertebra, and then patient has to do retractions, right? So it is a cervical retraining technique to relieve pain. So this is one of the cervical technique which was explained by Robin McKenzie to treat a patient with the neck pain symptoms. Supine retraction with head over the edge of the couch, and it's for the level of the thoracic vertebra is T3, T4. So next question we are going. Flexion, okay, PNF. As I told you, PNF. Flexion, abduction, external rotation of the shoulder, elbow flexion, forearm supination, wrist extension, and radial deviation, and extension of the finger is dash pattern. It's a D1 flexion, D2 flexion, D1 extension, D2 extension. Flexion, abduction, external rotation of the shoulder, elbow flexion, forearm supination, wrist extension, radial deviation, extension of fingers. So what is it? Is it D1 flexion, D2 flexion, D1 extension, or D2 extension? So just think over it. PNF are the patterns which we are applying as the patient using for daily activities. When the patient does ADL activities daily, we are applying the technique, right? Half of you told the right answer. It is D2 flexion. What is D2 flexion? You can see this picture. Please take a photo, download the photos in your from the website. This is very useful. What is D1 flexion? What are the movements occurs in the D1 flexion? What are the movements occurs in the D2 flexion, D2 extension, D1 extension? These techniques may also involve with the normal ADL activities, like D1 flexion is combing the hair, is a D1 flexion, right? So shoulder flexion, adduction, external rotation, forearm supination, wrist radial deviation, finger flexion. D1 flexion is combing the hair. When you ask the patient to comb the hair, it's a D1 flexion. Like that, ADL activities can be merged with the technique so that you are not able to forget it, right? So now, before the PNF or proprioceptive neuromuscular facilitation was applied for the patient with a neurological movement, but recently the PNF technique was also applied for the patient with the orthopedic conditions like musculoskeletal disorders, osteoarthritis of knee joint, arthritis of shoulders, neck pain. Also, they started doing the PNF technique. So we have to at least know the basics of PNF. Although you do not understand the whole principles of PNF, at least you are supposed to understand what are the techniques there and how they are doing it, right? As a growing to service, you are supposed to understand it. Okay, this is PNF, or we can consider as a muscle energy technique also. Both are same, right? So some techniques are both are same. I'm not saying both are equally important, but some of this. After the patient voluntarily relaxes, the therapist moves the patient's limb passively through an available range of desired motion for several times, so that the patient becomes familiar to the sequence of movement. Once the patient voluntarily relaxes, therapist passively moves the limb, right? So passively he takes the movement so that he can be familiar with the movement. What is this movement is called as? Is the repeated contraction, rhythmic initiation, slow reversal, or alternative isometrics. So repeated contraction, rhythmic initiation, slow reversal, or alternative isometrics. It's very good. Many of you has the correct answer is a rhythmic initiation, right? So you have to make the patient to understand that this is the flow of the movement takes place. So we are supposed to produce several kinds of movement, and the patient may have to understand, okay, this is the movement the patient is going to do. It's called as rhythmic initiation. Very good. Many of you have told the correct answers. Right, Maitland grading. Small amplitude rhythmic oscillations are performed at the limit of available movement and stressed into the tissue resistance, as the question itself tells the answer. Small amplitude rhythmic oscillation and stressed into the tissue resistance. Is it grade 1, 2, 3, or 4? Very easy. It's very easy. It's 4, right? So this is grade 4 because as we told earlier, as I told you, this is the grade 1, grade 2, grade 3, grade 4 as a diagram. Grade 1 is the small amplitude movements which are done at the beginning range of the movement, right? So it is a small amplitude rhythmic oscillating movements. Whereas grade 2 is a large amplitude rhythmic range of movement, but still not touching resistance. Patient have a resistance, we are not touching it, although we are giving a large amplitude of movement. Whereas grade 3 is also a large amplitude mode, we are just touching the resistance, mildly touching resistance, but with a large amplitude. Whereas grade 4 is a small amplitude touching into the resistance. We are touching and making the patient to produce a movement like shoulder flexion, elbow flexion, wrist flexion. We are just doing it into resistance to gain the range of motion. Right? And grade 5 is manipulations. Patient were powerless to prevent it. Just apply standard thrust like a high velocity thrust to the neck, high velocity thrust to the elbows, high velocity thrust to the knee joints. Right. So Maitland manipulations follows the gradings. Right. So everyone has asked you how to find the gradings. The gradings are you decide by yourself that this is grade 1, this is grade 2, grade 3, grade 4 comes upon practice. Your grade 1 is my grade 3, my grade 3 may be someone's grade 2. So it is everyone person, it is based on the total perception of the therapist. It has to be developed individually. Although the book says, the textbook says these are guidelines, but there is no stronger guidelines for this is grade 1, this is grade 2, grade 3, grade 4. So there is no such like that. You have to develop your own grades based on your perception. You have to feel it. You have to close your eyes, feel the rhythm of the movement and understand it. What movement you are going to, you are giving applying. It's a grade 1 movement, your grade 2 movement, grade 2 movement, based on the rhythmic oscillations, slow amplitude rhythmic oscillations or large amplitude rhythmic oscillations. There is no textbook has told you that this amount is grade 1, this amount is grade 2, right? So it is based on your performance, your perception only. Okay, this is one of the myofascial release technique. What is the name of the technique? The myofascial release technique, what is the name of the technique? What is the name of the technique? Any guess? Wrong answers also welcome. What is the name of the technique? So you told myofascial is and no muscles are touching, no faces are touching. The patient is just pulling the leg. It's a technique. It's not deep friction. It's not applying anything. Just pull the leg. As the answer says, it is a single leg pull. Yes, you just pull the leg, and we are going to stretch the whole lower limb fascias, as well as in upper limb pulls also. Hand pull also, leg pull and hand pull. Hand pull is such as the upper limb fascias, and leg pull such as the lower limb fascias, as well as fascia in the lumbar spine also. This leg pull not only in the MFR technique, but also this technique is very common in Maitland manipulation. It's inferior glide for the hip joint, so which helps to produces circumflexion movements in the hip joint. So it also comes under inferior glide. As I told you, it is a myofascial release. The myofascial release is single leg pull. If you say it is a Maitland technique, it is called as inferior glide for the hip joint, where we are able to improve the rotations. Right. So we know humeral anterior glide improves. So when you make the patient in a prone line and you are applying a anterior glide, what movement you are getting or what movement you will improve? Is it a flexion movement, medial rotation, external rotation, or elevation of scapula? Which movement you are going to improve when you do a posterior gliding? Sorry, anterior gliding. Kanya says it is medial rotation, Guinea says it is external rotation. Any answers? A, flexion. How anterior glide doesn't improve flexion? C, external rotation. Right, so the correct answer is C. When you apply a posterior glide, when you make the patient in a prone lying and you apply a posterior glide, so anterior glide. So when the joint goes for anterior, what happens when the glide? Automatically the limb goes for extension. extension and external rotation. I just voluntarily did not put the extension. I hided extension, but along with extension, the one movement is external rotation. External rotation will improve. Whereas the posterior glide, we have seen in the previous slides, posterior glide will improve flexion and internal rotation. So when you see make the patient supine lying, apply a glide on the shoulder, and that is posterior glide improves flexion, internal rotation. On anterior glide improves extension and external rotation. Right. Right. Same for the ankle joint. Talocrural ventral glide improves dorsiflexion, plantar flexion, inversion, eversion. Dorsiflexion, plantar flexion, inversion, eversion. Talocrural joint. So it is not, I will just tell you, it is not subtalar joint. Plantar flexion or dorsiflexion? So ventral glide is also called as anterior glide. So you make the patient in a prone-lying position and you do a ventral glide. There is anterior glide of the talus or the calcaneum. So when you does this movement, what happens is there is improvement in the plantar flexion. Right? So plantar flexion will be improved in the talocrural anterior glide. So you may be confused why this is improving the anterior glide improves plantar flexion, their anterior glide improves dorsiflexion based on the concave convex rule. I will have one slide on the concave convex rule. Right? So when you understand the concave convex rule, the articular surface, which surface is concave, which surface is convex, then you are able to understand which glide improves what. So why this anterior glide versus improves flexion? Why that anterior glide improves extension? Because we have to know about based on the concave convex rule, the congruity of the bones. Every bone has got different congruity. We have to understand the basic concepts of the bone and the anatomical structures to identify what happens when you apply what technique. Right? That is a basic thing you have to understand. The basic anatomy picture you have to create it before applying a manipulations, right? But it's very clear. All the textbooks says this, apply this technique, apply this technique. You can apply that technique and you identify what is that. Right, so 21st question on McKenzie manual therapy. Mechanical deformation of the soft tissue as a result of adaptive shortening. Is it a partial syndrome, derangement syndrome, dysfunctional syndrome, or positional syndrome? Mechanical deformation of the soft tissue as a result of adaptive shortening. Is it partial, derangement, dysfunction, or positional syndrome? Mechanical deformation of adaptive shortening. Everyone has given wrong answers only so far. Till Anjali, everyone has given wrong answers. Also wrong. Right, so I'll explain. So McKenzie has described the correct answer is dysfunction syndrome. McKenzie has described 3 syndromes only. One is called as partial syndrome, dysfunction syndrome, and derangement syndrome. The 3 syndromes which are explained with McKenzie. Partial syndrome occurs due to abnormal stress or abnormal poor posture. When the patient writes for a long time, poor posture causes neck pain. Is when you correct the posture, the patient pain will go away. That is happens only in the younger age group. There's no pathology is there because of poor posture. The muscle goes for tightness, and when you correct the postures, do some chin tucking, the pain releases. The patient becomes normal. Dysfunction is the person mostly comes above 30 years. There is an adaptive shortening of the structure because of prolonged forward flexion. There's a tightness occurs in the upper cervical spine or the upper cervical extensors. There's adaptive shortening. When you do chin tucking, the patient says, "Sir, pain is there." This pain occurs because of you are stretching the tissues. You are stretching the tissues causes pain. So that is adaptive shortening is a dysfunction. But still, adaptive shortening and partial dysfunctions are not a problem. When you do exercises, when you start retraining the muscles, the patient will become all right. Right? Whereas derangement syndrome is a mechanical displacement of the motion structures. Like best example is IVDP. So there's a disc prolapse of the cervical spine. The patient exhibits pain, sometimes radiating pain to the fingers, radiating pain to the shoulders, radiating pain to the elbow also. So this is derangement syndrome where the arrangement itself is modified. the disc may protrude out or the disc may bulge up and starts irritating the nerves, causes radiating pain. This takes a lot of time for the treatment and you have to do a lot of exercises. McKenzie has come, as I told you before, McKenzie has come up with the spinal manipulations, right? Spinal therapy only. McKenzie positional release. Positional therapy is for the cervical spine, that's for the lumbar spine. Cervical spine, they have set of exercises, and lumbar spine has got set of exercises. These are most of the McKenzie therapy are active techniques, and some of the techniques are passive only. But unlike Maitland or Mulligan's or Galton, all the techniques are passive. Here, McKenzie asks the patient to do the movement, like we saw in the previous picture, retraction technique out of the couch. Everything the patient has to do the movement, right? And some technique is there like neck high neck thrusting technique or mobilization of the facet joints are also there. But most of the techniques which are described by the McKenzie are all active technique. The patient has to do actively that exercises, and the patient has got benefits. Whereas the same as lumbar spine, also few techniques are there which mobilizes the spine. Other techniques are the active technique which helps the patient to do actively improvise. Right. So always remember when you speak about McKenzie, we have three syndromes only: postural syndrome, dysfunction syndrome, and deregulation syndrome. Postural is just a postural problem. Dysfunction is sometimes there's a longer duration of postural pain may result in dysfunction, right? So I'm keeping the posture for 6 years. I'm working as a computer operator, and the causes pain is a dysfunction syndrome. Deregulation syndrome is very simple as like it is a IBD, intervertebral disc prolapse is called as deregulation syndrome. Every syndrome has got different set of exercises, but very easy to learn compared to other manual therapy. McKenzie is comparatively easy to learn. Right, this picture is a barrier concept, right? So you have to understand what is barrier concept before you are going to apply for a manual therapy, right? So anatomical barrier is the barrier where it is the last thing. After that, there is no movement occurs. Like elbow extension is the anatomical barrier. After that, if you produce movement, results in dislocation or fractures. Elastic barrier is the end of the passive range of motion. The gap between the elastic barrier and anatomical barrier is called as what? What is the name of the space between the anatomical barrier and the elastic barrier? It's not plastic. Okay, very good. Right. I appreciate it. Elastic barrier. Okay, end range of passive range of motion is called elastic barrier. End range of active range of motion is called as the okay, this is called as para-physiological space. The space is called as para-physiological space, where when you apply a high velocity thrust, you feel a click sound, right? So this click sound happens when you enter into the para-physiological space. So all these click sound happens when you are going into the para-physiological space. So it's called as para-physiological space. This is the barrier concept. I just put one part. The barrier concept itself is a big class. Very easy one. Based on anatomical structures, we are going to. Right. Question number 22. Vague, aching, burning, diffuse, and widespread pain is seen in trigger point, fibromyalgia, chronic fatigue syndrome, or rheumatoid arthritis. Vague, aching, burning, diffuse, and widespread pain. The patient comes in, sir, I have pain in the neck, I have pain in the back, in the fingers, in the knee joint. So usually patient comes with all the history. What is that pain usually we call it as? Is it a trigger point pain or fibromyalgia, chronic fatigue syndrome, or rheumatoid arthritis? Sometimes patient with rheumatoid arthritis exhibits these syndromes. Very good. Everyone has put a correct answer. It is fibromyalgia. Patient comes with a whole body pain. Usually it's described as a fibromyalgia, right? So they don't have any single area of the pain. But rheumatoid arthritis patient has a pain in the fingers, in the early morning stiffness, or pain in the knee joint with the early morning stiffness. They come with the clear history of the arthritic changes. But these patients with the fibromyalgia, they say sometimes burning pain. So I just asked some patient to apply ice in the neck pain. Neck, they said it starts burning like sensation, right? Because when you keep ice and patient starts burning, it is not because of some physiological changes, right? So it's a fibromyalgia. Right, so we are going into another muscle energy technique questions. Technique which decreases muscle tone in a single or group of muscles after a brief period of submaximal isometric contraction of the same muscle. Technique which decreases muscle tone in a singular group of muscle after a brief period of submaximal isometric contraction of the same muscle. It's a reciprocal inhibition, or a post-precipitation stretch, or rhythmic initiation, or a post-isometric relaxation. Reciprocal inhibition, or post-precipitation stretch, rhythmic initiation, or a post-isometric relaxation. Supraja has come up with the right answers. Right? It is the post-isometric relaxation. So this is one of the muscle energy technique. Right? So muscle energy technique and EPNF techniques more or less has got same principles. It works on the same principle. Very, very easy question. Which nerve stretch in this question? Please tell me what is this? Butler's mobilization is also called as if you are able to do that. Very good, excellent. So what is the name of the technique? This is Butler. Prone knee bending technique, which helps to stretch the femoral nerve, right? So, which was explained by the Butler. So, when you ask the patient to lie prone and passively also, you can make the knee to touch the buttock, the patient will stretch. If the patient doesn't feel a stretch, we can also extend the hip joint mildly to stretch the femoral nerve. Right? Very good. Everyone has put a correct answer. This is a femoral nerve stretch. Okay, so main concept of Mulligan's manual therapy. Although all these answers are correct, I want exact answers. Pain reduction, improvement of range of motion, quality of life, or question of words. What is the main point here? Everything is right answer only. I am not saying it's Mulligan's will not reduce pain, will not improve quality of motion. Everything is right, but still, which is the appropriate answer for this question? It's not improve range of motion. Mulligan, when you read the Mulligan's concept, you are able to answer it very clearly. It's just like that. Mulligan says it the pain occurrence because of the positional faults, right? So he says it is a positional fault. When you correct the positional faults, you are able to bring them back to the normal position. That's why Mulligan's technique are all in the weight bearing questions. Whereas other manual therapy will make the patient in a relaxed position, keep the joint in the relaxed state, and then do the manual therapy. Whereas Mulligan's technique are all done in the weight bearing positions. Lumbar spine and all make the patient sit and do the technique. So that when the patient stands and walks, the patient will not find pain. So the main concept of the Mulligan is to correct the positional faults in the joints. The last question. When the tibia moves over the femur, on the posterior direction, rolling and sliding occurs either in the same direction or opposite direction. Very simple. That's what concave convex rule. We'll finish off today's session with the concave convex rule. So either it goes in the same direction or opposite direction. The tibia moves over the femur. When you bend your knee, it's the same direction, opposite direction. It is same direction, right? Very, very good. So this is how the concave convex rule is there. When the convex joint is a stable joint and the concave surface is moving, rolling and bone movement occurs in one direction, sliding occurs in different direction, right? So when I flex my shoulder, the rolling occurs in the posterior direction, whereas bone movement, sliding occurs in the posterior direction, bone movement occurs in the anterior direction, rolling occurs in the anterior direction. And the same as when I do abduction, the bone movement and the rolling occurs superiorly, whereas the sliding occurs inferiorly. Here, when the convex surface is moving, concave surface is moving, convex surface is stable, rolling, sliding, bone movement occurs in the same direction. When you flex the digits, when you flex the digits, the bone movement or the rolling, sliding occurs in the same direction. Right? So based on the anatomical bony alignments, the movement occurs. Right? So concave convex rule is the basic for any manual therapy. When you open any textbook of manual therapy, has this concave convex rule with different pictures. The pictures are different. This concave convex rule was told by Kaltenbaum. Freddie Kaltenbaum. Sometimes he was called the father of manual therapy also. Right? Freddie Kaltenbaum. Right, the last question. So what is this PNF pattern? how the Shahrukh sits, what is the PNF pattern? Last question. We are going to end up with this session. A lower limb only, not for upper limb. Please don't confuse. It's lower limb. What is the PNF pattern? Right, very good. Okay, so those who type the answers are right answers. One is D1 flexion, right? So D1 flexion means flexion, adduction, external rotation. And so when you ask the patient to do this movement, that's what I always advise. Please learn PNF based on the normal ADL activities, because most of the ADL activities will be encapsulated in the PNF patterns. When you read the ADL activities, you don't forget the PNF patterns, right? So when you see Shahrukh next time in the same posture, remember it's a D1 flexion of the lower limb. Shahrukh is doing a flexion, adduction, external rotation. Any person who sits that, you think that it's a D1 flexion. Right. So from this, the last slide of Basha, we are going to complete our session of today. So you can find a lot of questions in my textbook. Okay, that's all for today's class, and as discussed with Dr. Chandra, and we have next class on 46th, next Wednesday, right? And so as we completed some chapters in the physiotherapy, I just want to have a brush up in the exercise therapy. Although there are so many techniques, so many chapters in exercise therapy, it is impossible to cover all the chapters of exercise therapy in the same day. So I am dividing into 3 or 4 parts in exercise therapy, sir. Kindly give some time to take classes.
Yes, sir.
So the topics also I put in the group also later. The basic physics, Fascial,
yes, sir.
So this 6th chapter, please study through it. We'll have questions on 26th, next Wednesday. And as I told before, I have also shared a few questions to Dr. Chandra. You can please, he might share you in the WhatsApp group. Please find appropriate answers. Right? Thank you very much for the opportunity. Thank you, Chandra sir.
Thank you, sir. If participants have any questions or any doubts, they can discuss now. Even those who are watching in YouTube, you can put your questions. I can read it here. No worries. We will take another 20 seconds to react to this. Dear participants, any questions to ask? I'm asking the Zoom now. No questions means kindly type.
In the WhatsApp group, we have the questions will be shared on the manual therapy.
Yes, sir. Yes, sir. I will post it tonight. Yes. And those who are answering, they are eligible for a next special lecture. And that's how we can encourage. Otherwise, we won't get any response properly. People are doing it right away, sir. Actually, to attend special lectures, they are answering. Truly sincere persons. No questions, sir. No questions from YouTube also. We can wind up, sir. You have muted, sir. You have muted, sir.
Yeah, thank you, sir. Thank you, sir. See you. Good night, all the participants.
Thank you, sir. Wonderful session, sir. Actually.
Thank you, sir.
Wonderful session, sir. Actually. Thank you so much.
Bye, sir. Bye, bye. Good night, sir.
Thank you all. Good night. Good night. Good night, madam.